successful from a successful group of publishing people in Boston from Bethesda Deaconess Medical Center. He specialized in anesthesia. I think he trained in Germany and then went there. And then Danny Talmor hired him and never gave back his passport to go back to Germany. And he does, I think, a very peculiar type of research, which I am fascinated by, because he's one of the only very few groups in the world that can link big data with physiology. So usually is either big data or physiology, small studies. Instead, Max and his group always try to link the two, the big data that comes from large data sets and the physiology behind respiratory pathophysiology. Today, we speak about a very hot topic, so how to ventilate the lung in the operating room, and I think maybe also, Max, in the transition from the operating room to the ICU is a very interesting area. And the idea is that we can't rely on average values for everybody, but as in all medicine now, we should personalize. Go ahead, Max. Thank you for joining us.
Thank you, Tommaso, for this really kind introduction. Yeah, to me, of course, it's a great pleasure to talk about mechanical ventilation in Milan. To be honest, it makes me a bit nervous because it's a bit like preaching to the Pope. So, for example, Giovanni's papers are already read as a medical student. We are doing is exactly what you say. What we are doing in Boston is we're trying to leverage large data sets to answer a clinically relevant question, but at the same time also maybe in a novel approach go back to more basic principles and couple these with physiological links. And I would like to talk a little bit about this in the setting of perioperative mechanical ventilation. I know a lot of residents here come from an ICU training program as well, and I think a lot of this also applies to the ICU and overall to patient with healthy lungs. And we're revisiting some basic principles about mechanical ventilation again. As you said, I'm living in Boston for 7 years now. I was born and raised in Düsseldorf in Germany, which is not that far from Milan. And if you ever get the chance, it's a beautiful town in Western Germany that has a really nice inner city. We call it the longest bar in the world because there's a lot of pubs and bars where you can drink really dark, savory beer. It's always a good place to go and to visit. There's a huge fair in July. That's actually the biggest fair in Germany in terms of visitors per day, so even bigger than the Oktoberfest. So that's also another opportunity to go to Düsseldorf. And even though Danny Talmor took my passport away, I'm still somehow able to travel there like twice a year at least. I'm also very happy to talk in Milan because of this really strong connection between these two cities, Boston and Milan. And this is the group of basically Milan refugees at BIDMC. You can see in the middle Riccardo Pinceroli, who I think used to be residency director in a major hospital in Milan. And he joined BIDMC just 1 year after I did. And he's a really good friend of mine. He's the director of our transplant anesthesia program now. And next to him, you see Maurizio Bottiroli, who's doing cardiac anesthesia and ICU at Beth Israel. Both really good friends of mine. On the right side, Simone Rediali, who spent 2 years in my lab and is now at MGH. And then Jacopo Colombo behind him. I think probably many of you know him as well. He was at BIDMC and he went back to Milan. And then Dario Winterton on the very left side, who's also part of my thoracic anesthesia division. These are my disclosures. So when we talk about intraoperative mechanical ventilation, of course we have to talk about if it really matters. I mean, as opposed to the ICU, we ventilate the patients in the OR only for a few hours. And this, of course, gives us a much smaller time window where we can do harm or good. Well, it matters first of all in an epidemiological sense because already in 2012, the estimated global volume of surgeries was about 330 million, and about 230 million worldwide in this per year were done under general anesthesia. And it's since although we don't have any newer numbers than this in the last 14 years, it's extremely likely that this number is even much higher now. And 3 to 5% of these patients develop postoperative lung injury and pulmonary complications. And if you just do the simple math, that means millions of patients each year who undergo general anesthesia will develop pulmonary complications. These complications are extremely, or are very closely linked to outcomes. So on the left side, you see overall survival in patients with and without pulmonary complications. And they are actually, when patients develop pulmonary complications, they're the only postoperative complication that is linked to increased mortality, irrespective of patients' baseline risk. So they are a big problem, of course, for sick patients, but they're also a big problem for healthier patients. And they are overall contribute substantially to the global burden of perioperative morbidity and mortality. There are many different scores to predict pulmonary complication. There's the Las Vegas score. There's the RSGUT score. A lot of instruments exist. This is just because this is I'm showing the SPORC score here because it has been developed in Boston at MGH and via the AMC. But what's most important here is that when this study where this score was published first showed that when reintubation occurred within 3 days after surgery, it led to a 72-fold mortality increase. So just again showing how important it is to prevent severe pulmonary complications after surgery. And of course, we're talking here about a multi-etiological phenomenon. So there are a lot of things that can lead to pulmonary complications. There's a lot of things that can lead to trauma. There are also a lot of different types of trauma. So this is a type of trauma that Germans are still very present. That was the Euro World Cup in 2012 when Balotelli scored 2-1 against Germany in the semi-final and basically kicked Germany out. Huge trauma, but luckily that is not really relevant for most of our patients. So what I want to talk today about is in the perioperative setting, how does lung injury and atelectasis impact pulmonary complications, and what can we do to improve our patient outcomes? So where are we coming from? This is a publication that probably many of you know from Bennigsen and colleagues, most notably also John Hadley White, who was one of the first chairs of anesthesia in Boston in 1967. And actually this year, only last month, passed away at I think 96 years old. And what they saw in this study was that when they ventilated patients with higher tidal volumes, that they overall had improved oxygenation in these patients, and they showed a much lesser degree of cyanosis. And this was, of course, in the setting of absence of PEEP. So coming from this landmark publication in 1963, just looking at oxygenation, the use of high tidal volumes, and we're talking here about 12 milliliters per kilogram body weight, predicted body weight, substantially improved oxygenation in patients. And that was one of the bases why patients in the ICU and also of course in the operating room have been ventilated with high tidal volumes for a long amount of time. But of course, we know now that high tidal volumes carry high strain and in secondary can cause also high stress in the lungs due to higher intrapulmonary pressures or transpulmonary pressures ultimately. And this was already shown in 1974 by Webb and colleagues in animal models that when you ventilate rat lungs with high transpulmonary pressures over a long amount of time, you can cause substantial lung injury, inflammation, edema, and ultimately and tissue disease. So the way we are currently envisioning the how perioperative pulmonary complications or perioperative lung injury occurs is that we have two injuries. One is strain from high tidal volumes, one is stress from high pressures, and they act on the lung and the patient's respiratory system in a setting of high susceptibility, meaning that patients undergoing surgery, obviously they are not just mechanically ventilated, they have a lot of other things going on, most notably the stimulation from the surgery that causes systemic stress and inflammation. And in conjunction with potential cyclic collapse, this can then lead to lung injury and lung tissue injury, and that then translates into pulmonary complications. That intraoperative mechanical ventilation by itself matters. I think has most notably been shown by the IMPROVE study. So this is a French study that was published in the New England Journal about 13 years ago, where they randomized 400 patients undergoing major abdominal surgery and to either high tidal volumes without PEEP and versus low tidal volumes with PEEP and repetitive recruitment maneuvers. And the outcome here was a composite outcome of pneumonia, mechanical ventilation, sepsis, or death. And as you can see here in this figure, that at day 7, 28% of the patients in this non-protective ventilation group had this outcome versus 11% in the lung protective ventilation group, which was a substantial effect size. Very impressive. The same group around Samir Jaber and colleagues, they reproduced the study in one lung ventilation. Patients undergoing one lung ventilation, flobectomies and pneumonectomies. Very similar protocol, little lower tidal volumes because of the one lung ventilation setting. And they saw a very similar effect size also in these patients undergoing thoracic surgery. So these two studies, in conjunction with many others that use different outcomes, at that time established that intraoperative mechanical ventilation matters. And what we also saw at that time was that while in the ICU, and I'm not going into all the ICU tidal volume studies, most notably the ARDS-NET study in 2000, there was a substantial decrease in tidal volumes over time. That was not as consistent on the right side in the OR. So these are observational studies, and we basically, what we did at that time, that's already 8 years ago, we analyzed the tidal volume in these observational studies, the mean tidal volume, and just plotted this over time. And in the operating room, it was not as consistent. And that was also due to some negative studies. So it's a smaller study that we did when I was still in Düsseldorf in Germany. We randomized 100 patients, and we kept PEEP similar for both groups and randomized them to high versus low tidal volumes. And the primary outcome, because it was a smaller study, was postoperative lung function, and that is debatable if that's a good outcome and it captures it well. But if you look into the pulmonary complications, they were also pretty identical. And had we hypothesized an effect size that the groups around Samir Jaber and colleagues saw in their impact studies, then we would have seen a difference. So there was no difference. And later study by Karalapila and colleagues from Australia reproduced these findings, primarily powered on clinical relevant outcomes now, postoperative pulmonary complications within 7 days, and they randomized over 1,200 patients. And also saw, so again, high tidal volume versus low tidal volume, PEEP constant in both groups, and they also saw no difference. So at that time, the question was, okay, if it's not the tidal volume, then it must be the PEEP, right? Because the Samir Jaber and the French group, they saw such a huge difference when randomizing patients to low tidal volume with PEEP versus high tidal volume without PEEP. So it must be the PEEP. Well, there were 2 large multicentric European studies from around the group from Marco Schulz and colleagues and Marcelo Gama de Abreu, and that was coordinated through European Society of Anesthesiologists. One was the Provilo study, and we actually also participated in both studies when I was still in Germany. Provilo study randomized patients to basically 0 PEEP, so less than 2 centimeters of water, or whatever the ventilator allowed as the minimum setting, versus 12 centimeters of water, and they saw 0 difference in pulmonary complications. And on the right side, the ProB study, which was basically the same study only in obese patients, where the assumption was that a high PEEP would help these obese patients, and the same thing, they didn't find any difference. There was another study a little bit more recently from the Outcomes Research group in Cleveland in the United States, And they did a factorial design. So what they basically did was they randomized patients to 6 versus 10 milliliters per kilogram ideal body weight, so low versus higher tidal volumes, and then again to 2 different levels of PEEP, effectively creating 4 groups with like low tidal volume, low PEEP, low tidal volume, high PEEP, and then the same for higher tidal volumes. And they also did not find any differences in postoperative pulmonary complications or postoperative desaturation. So at this point, the overall landscape in the literature was a little bit, or is a little bit like confusing, right? So like if it's not individually tidal volume, it's not individually PEEP, but in combination, they have a huge effect on our patients in the operative setting. What the heck is going on? Well, first of all, one size does not fit all. This is a really interesting study published in the British Journal of Anesthesia by Wirth and colleague, who looked at the intratidal compliance profile in patients undergoing surgery at standard settings of a PEEP of 5 centimeters of water and tidal volume around 6 to 8 milliliters per kilogram predicted body weight. And what they did was, if you look on the right side, so the intratidal compliance is basically the compliance at any given point doing lung inflation, doing regular mechanical ventilation. And you see, like, you can start on the lower end, and if your PEEP is insufficient, you start in a lung that maybe has some atelectasis, and then you're opening up the lung. And while you're opening up the lung, the compliance of the lung increases, and then you reach this this point where your lung is fully open, and you basically achieve maximum compliance at this given point. And if you're then, if you're then continuing to ventilate to inflate the lung, at some point you reach overdistension. So your compliance drops down again. And the idea was that if you have an optimum PEEP and you have an optimum tidal volume, you really just ventilate at this like very steep part of this pressure volume curve, of the inspiratory limb of the pressure volume curve. And that would give you a horizontal compliance profile because the compliance would be the same over the whole tidal breath. And what they saw was that only 4.2% of patients had this optimum intratidal compliance profile. A lot of them had an increasing profile, which meant that that mechanical ventilation started with probably an insufficient amount of PEEP, and the lung recruited first. And some patients even had a decreasing compliance profile where some overdistension was involved. So I think this study nicely shows that these standard settings that we're using, like one PEEP for all patients, is extremely insufficient for most of our patients. It just doesn't fit. One size here doesn't fit all. And then we're coming to PEEP individualization. So the question is, if we individualize PEEP for our patients, does this have an impact? And the gold standard for PEEP titration is a decremental PEEP trial. Decremental PEEP trial, you increase the PEEP to a high level, about 20 centimeters of water. Ideally, you take like 1 minute per steps and then decrease it by 2 centimeters of water and measure the compliance or the driving pressure at constant tidal volume for each PEEP step, and then you get an idea of which PEEP yields your best compliance. And this is what this group, or like many of these studies, did. And it has been extremely effective during one-lung ventilation. So for PEEP optimization, the evidence is very strong in patients undergoing one-lung ventilation, and I'll explain a little bit to why that is. But what you can see here, first of all, that you can substantially improve intraoperative oxygenation. This is a meta-analysis that was published in Critical Care last year, where you can see that patients that receive individualized PEEP have a substantially improved PaO2 and also P/F ratio on the lower side. But in this meta-analysis, the authors were also able to show that it decreases postoperative pulmonary complications. And again, we're talking about PEEP titration after one-lung ventilation. And the question is, why is it so effective during one-lung ventilation? So a little excursus into thoracic anesthesia. The systemic oxygenation during one-lung ventilation, so when I really only ventilate one of the two lungs, the two sides of the lungs, is extremely dependent on the perfusion of the non-ventilated lung. So if you look here on the right side, on the right upper, you see PaO2 on the y-axis and the percent of perfusion of the non-ventilated lung. So how much blood or how much tissue of the non-ventilated lung is perfused with blood, or how much blood is going through the non-ventilated lung. You can see when the non-ventilated lung is very well perfused, there's a lot, there's a substantial decrease in PaO2. And if we look into, and of course, perfusion of the lung is determined by the vascular resistance of the lung. And the vascular resistance of the lung is determined by two groups of vessels, like small vessels, like especially arterioles, and large vessels, so larger arteries leading to the lung tissue. And what you can see it at the residual volume, so when the lung is fully collapsed, the PVR is high because of large vessel occlusions. So here, the large vessels basically collapse as well or get compressed, and that results in an intrapulmonary increased vascular resistance. And as we recruit our lung, once we reach FRC, the overall pulmonary vascular resistance goes down. And once we start then further recruiting the lung and increasing the intrapulmonary pressure, you can see that the pulmonary vascular resistance goes up again in this lung, especially due to compression now in the small vessels. So there's two different effects, like on both ends of the curve, around atelectasis, but also around recruitment and overdistension, you get an increase in PVR. And this leads to a very interesting response curve around the optimum PEEP during one lung ventilation when you look at oxygenation. So on the left side, you can see that when the PEEP is below optimum, you have in the ventilated lung, you have atelectasis and you have high PVR due to a high pulmonary vascular resistance, especially in the large vessels. And then you're shunting through the ventilated lung, of course. And there's some shunt in the non-ventilated lung, but here the shunt in the ventilated lung dominates. Once you reach optimum PEEP, you're basically balancing collapse and overdistension in the ventilated lung, and you're decreasing the shunt in the ventilated or dependent lung. And then when you increase PEEP further and you're basically over PEEPing, the high PVR in the ventilated lung causes redistribution of blood flow towards the non-ventilated lung. So this is why it's also clinically easier to show that individualization of PEEP has a good clinical effect in one lung ventilation, because we have these effects on both sides of the spectrum. And I think that's also why it's so effective in improving oxygenation during one lung ventilation. So when we look at the studies in the OR, we do have to separate the one lung ventilation studies from the overall ventilation studies. There are other large studies. This is a study from Spain by Ferrando and colleague, published in Lancet Respiratory Medicine, that showed the effect of PEEP individualization, the iProf OLV study. So two groups, one group was received individualized PEEP, and one group basically received a standard PEEP. They were both combined either with individualized high flow postoperatively or standard oxygen in the low PEEP group. So it's in this study, it's not exactly clear where we can attribute the effect to, but at least the individualized PEEP as part of the intervention group showed a substantial reduction in the probability of postoperative pulmonary complications. So I think this shows that individualization of PEEP is very effective during one lung ventilation. But of course, most of our patients are not undergoing this little bit more specific setting of thoracic surgery, especially pulmonary surgery, but are undergoing two lung ventilation during general anesthesia. And we have to ask ourselves, and we cannot ignore the designation trial which came out this year, is individualized PEEP really relevant or helpful in patients undergoing general anesthesia with two lung ventilation? And this trial was negative. So we have to talk a little bit about this. So what did they do? They randomized patients to an individualized PEEP strategy that they call high PEEP, and versus a low PEEP strategy where basically intraoperative ventilation was not, or PEEP was not individualized, but where the group received 5 centimeters of water. They conducted in the individualized group a decremental PEEP trial, and this trial, basically the PEEP was reduced by 2 centimeters of centimeter water steps every 20 seconds. So it was a very pragmatic decremental PEEP trial until a minimum PEEP of 6. In previous studies, the steps lasted much longer, with the rationale that you have to basically give it a certain amount of time for atelectasis to occur, or for derecruitment to occur, and which you only then see in changes in compliance or driving pressure, depending on how you measure it. The identification of PEEP was a bit obscure, so they identified the highest PEEP with the lowest driving pressure, meaning that when different PEEP steps yielded similar driving pressures, the highest PEEP overall was chosen, and if there was no plateau, if there was no minimum driving pressure, an empiric PEEP of 12 centimeters of water was chosen. And the group who conducted or designed this designation style was trial was the very similar group to the Provis and Provilio studies. So you can see a little bit that this was influenced by this. And again, the low PEEP group received 5 centimeters of water. They did achieve pretty good separation of PEEP, at least a good distribution. So you can see this is the distribution of PEEP in both groups. So the low PEEP group all got a PEEP of 5, and in the high PEEP group there was a certain variation, and the median PEEP was about 10. When you look into the intraoperative complications, what is interesting is that you can see that the rates of desaturation on the top were much higher in the individualized, in the control group, and this was a little bit expected. So also as a proof of principle, they were able to improve oxygenation intraoperatively and avoid desaturation more through this intervention. But at the same time, the incidence of hypotension and use of vasoactive agents was higher in the individualized group due to higher levels of PEEP. What is interesting is that this trial also did not really achieve a good separation driving pressure. So this is the driving pressure, the difference between plateau pressure and PEEP over time between these two groups. And you can see, especially like between the first and the second hour, the difference in driving pressure was around 1 centimeters of water. So very low. And in order to entangle studies in the operating room, the concept of driving pressure is extremely helpful. So Amato and colleagues in 2015 published the concept of driving pressure, so the difference between plateau pressure and PEEP, and we're coming back here to patients with ARDS. And what they saw was that in the secondary analysis of RCTs, that when at the same PEEP levels, the driving pressure increased, that was directly linked to an increase in intra-hospital mortality. Whereas when with increasing levels of PEEP, the driving pressure was constant, that also led to constant risks of mortality. And when increases in PEEP led to a decrease in driving pressure, there was a substantial reduction again in intraoperative mortality. And what they were at that time able to identify was a threshold of around 13 centimeters of water for the static driving pressure of the respiratory system as a threshold or potential threshold for harm in ICU patients. So if we go back now and look at all these RCTs between the negative RCTs and the positive RCTs, and especially the lower complications in the IMPROVE studies, and then basically the IMPROVE and one-lung ventilation study, you can see that these studies achieved a very substantial separation in driving pressure. So in the IMPROVE study, there was 16 centimeters of water in the non-protective group and 9 centimeters of water in the non-protective group, and 9 centimeters of water in the protective group. And also in the one-lung ventilation study, the driving pressures were substantially different. When we look into the Karalapilai study, especially, the separation in driving pressure, and also Turan and colleagues, was much less. So you can already see that, like, of course, this is like an observation of studies and hypothesis generating now, but the separation in driving pressure seems to really predict the success of intraoperative mechanical ventilation in a study. And why were the Foutier studies so effective in reducing driving pressure? Well, because of course they randomized to 2 interventions. They didn't just randomize to high versus low PEEP or high versus low tidal volume. They combined these two. And if we go back to our pressure volume loop first of all increase the PEEP, on average in our patients we move our start of ventilation towards the more compliant curve of the pressure volume loop. And at the same time, when we then limit our tidal volume through the use of lower tidal volumes, we avoid reaching this high this part of overdistension. So these like 2 interventions together were obviously very effective in lowering the driving pressure. And Ari Sepaneto and colleagues really elucidated the role of driving pressure in these studies through a very interesting individual patient data meta-analysis that they published in the Lancet Respiratory Medicine in 2016, where they showed that the randomization to protective versus conventional mechanical ventilation in OR studies was basically that the effect of this randomization was 100% driven by driving pressure. So this is what we call a mediation analysis, where you can see which, or we can investigate which effects on the pathway between the exposure and the outcome are really responsible for the effect of the outcome or for the overall effect. And you can see, yes, the randomization achieved lower tidal volumes, it achieved higher PEEP values. But when you adjust this for the differences in driving pressure, the achieved difference in driving pressure led to a significant reduction in pulmonary complications development. And this is a really important lesson here, because that means that tidal volumes are only, or low tidal volume ventilation or the use of PEEP are only effective when they lead to a reduction in driving pressure. And this is now where we come in with our data. So this is one of the studies we did around this topic. So we leveraged data from over 260,000 patients, and we looked at the risk of postoperative pulmonary complications depending on whether high or low tidal volumes were used. And in this case, it was dichotomized at around 8 milliliters per kilogram because that reflected mechanical ventilation practices also a bit more, but you can see the same results if you use a threshold of 10. And we looked at this risk depending on the patient's respiratory system elastance, which is the reciproc of compliance. So on the left side here, you have patients with high compliance, and on the right side, you have patients with low compliance. And you can see as the compliance decreases, the more harmful high tidal volumes get. And at around a threshold of 42 milliliters per centimeter of water at a patient with an ideal body weight of 70 kilograms, these higher tidal volumes only became harmful. And in patients with normal or better compliances, there was actually a comparable risk between those. There was no effect of higher tidal volumes. And interestingly, and this is still a very under-investigated field, in patients with very high compliance, higher tidal volumes appear to be harmful. And that was something similar that another group also found in an observational study, but that definitely needs to be looked at further into prospective studies. And this is, of course, a field where we are far away from the pulmonary mechanics of patients in the ICU, and where what we see much more in the operating room in patients with healthy lungs. So, and then we looked again into the association between driving pressure and postoperative respiratory complications, and compared to the risk in the average patient populations, patients with a driving pressure of 14 centimeters or more had a higher risk of pulmonary complications. So that interestingly reflected very much the threshold by Marcelo Amato and colleagues. The difference here is that the driving pressures that Marcelo reported in his secondary analysis and of RCTs were probably more closer to static driving pressures, whereas our driving pressures, even though there was an inspiratory hold, are probably a little bit more dynamic. And so our threshold here has to be taken with a grain of salt. It could be a little bit lower actually. So yeah, but this is obviously a really interesting information, because I think it's so nicely supports that one intervention, especially in mechanical ventilation, does not affect all patients in the same way. And if you really want to look into the effect of higher tidal volumes, you have to look into patients with lower lung compliance. At this point, I like to give especially anesthesiologists a little bit of an idea of how they can individualize in the operating room. And for the residents coming from an ICU standpoint, some of this might feel a little bit archaic, because the ventilators in the operating room don't have the same capacities as the ventilators in the ICU. And I'll show you a little bit how we approximate some of these functions. So this is a patient that is a good example. It was a 78-year-old female patient with obesity, BMI 37, undergoing robotic hysterectomy. And I also like to take this example because also in the United States, and I'm sure the same in Europe, robotic surgeries are really on the rise. So there's a strong strong movement, even moving from laparoscopic surgeries to robotic surgeries. This is fueled by some studies that showed improved outcomes with patients undergoing, for example, sigmoidectomies, reduced improved cancer-free survival, even compared to laparoscopic surgeries. And it's at Beth Israel, we are now running, I think, about 7 rooms on robotic surgical rooms each day. So it has really picked up. And I think that carries a lot of implications for us as anesthesiologists and also for mechanical ventilation. But coming back to this patient example, so this female patient's undergoing robotic hysterectomy. That's a shot of our ventilator. We use Mindray ventilators, but obviously that doesn't really matter here, because you can do the same thing with Dräger or with whatever you're using, GE. So this patient, after intubation in the supine position, was ventilated with the standard settings of PEEP of 5 and with 8 milliliters per kilogram predicted body weight tidal volume. And the first thing we wanted to know is what was the driving pressure in this patient at this point. So in order to measure driving pressure, you really want to measure the static driving pressure. So that means you need an end inspiratory hold, where the pressure in the machine at the end of inspiration can equilibrate with the pressure in the patient's lungs. If you're not doing this, you're measuring dynamic driving pressures, and they also give you a lot of information, but they're always impacted by airway resistance and inspiratory flow. So ideally, end inspiratory hold in the ICU, just hit a button in the OR. We cannot do this because our ventilators cannot do this. But there's this, they have this function that's called here T-pause. It has different names, and that means it attributes 40% of the inspiratory time now to an end inspiratory hold. And when you do this, you get a meaningful plateau pressure, and in this patient, the plateau pressure was 18, and that resulted in a driving pressure of 13 in the supine position. Okay, not great, not really bad, but we can optimize this. So what we're doing in the operating room is we're optimizing this using pressure volume loops, because if we do a decremental PEEP trial, the surgeons will kill us. And what you can do, again, we're coming back to the inspiratory limb of our pressure volume loop. You can, if you reduce your inspiratory flow using very low respiratory rates, and then use 10 milliliters per kilogram ideal body weight with an IT ratio of 1:1, you really reduce your inspiratory flow to like below this threshold of like about 9 liters per minute. Where you really get a meaningful pressure volume loop under volume controlled ventilation. And then you can see how the intertidal compliance changes and where the lung really opens up. And we investigated this. This hasn't been published yet, but we compared this to the results from a decremental PEEP trial and also EET-derived PEEP trial. And what we saw was that the mid-inflection point, so the mathematical point where the inspiratory limb of the pressure volume loop reaches its steepest compliance, was on average around 1 centimeters of water next to what you could get from a decremental PEEP trial. So very closely reflecting with a much easier move. And when we look at this point where this curve, this inspiratory curve, reaches its steepest compliance, for this specific patient it was 10. So what we did now was We recruited her up, and we came out after the recruitment maneuver at a PEEP of 10, and that substantially reduced the driving pressure from 13 to 9. So now we're ventilating her with a driving pressure of 9. Great. Problem is, surgery now happens. So what's happening intraoperatively? The surgeons, especially for hysterectomies, they use a robotic hysterectomies. They use very steep transdermal position. They insufflate the abdomen with about 20 centimeters of water intra-abdominal pressure. So when we measured the driving pressure after the surgery commenced, it went up to 27 because the plateau pressure now was 37 at the same PEEP of 10. So we used this very simple tool to retitrate PEEP, and we saw now that in this extreme positioning, the requirements for PEEP substantially increased. So the optimum PEEP now was around 24. So we recruited her up, we ventilated her with a PEEP of 24, and all of a sudden the driving pressure dropped again to about 10 centimeters of water. So I think this is if you want to individualize ventilation for your patient, I think this is a really nice approach to do this. And I think it's also important that obviously when patients undergo ventilation in the OR, things change, as opposed to in the ICU, where most of the time the positioning and all that is still the same. So that really helps you that not to just individualize at the beginning of ventilation, but also to just do it again and again. At this point, we have to ask ourselves, is driving pressure really the end? So if we optimize driving pressure doing intraoperative mechanical ventilation, is that the best we can do for our patients? And if I'm asking you like this, and obviously you are in Milan, the question is, no, it's not. This is a study also from our Boston data set in about 100,000 patients, where we looked at the effects of respiratory rate on postoperative pulmonary complications, adjusted for a lot of like intraoperative factors, and also matched by ABGs in a subcohort, so by arterial blood gases. And what we saw was that intraoperative respiratory rate was associated, a higher intraoperative respiratory rate was associated with a higher risk of pulmonary complications. And that leads us back to Milan, because now we have to add some things to our model of perioperative lung injury. And we are not talking anymore just about stress and strain and susceptibility, but we have to talk about repetition. And it makes perfect sense, right? If you have a harmful stimulus that I repeat with a higher frequency, of course, that's going to cause more trauma. If Italy beats Germany 4 or 5 times in a row, as opposed to 1 time in a row, that's going to cause more trauma among the Germans. And interestingly, if you go back to the studies around intraoperative mechanical ventilation, and especially like as an example, the Karalapilai study that randomized to high versus low tidal volumes, you can see that the respiratory rates were also very different in these two groups. So of course, clinicians targeted the same end tidal CO2 values, and in the high tidal volume group used lower respiratory rates than in the low tidal volume group. So how can we now account for this interplay between tidal volume, the inspiratory pressures, and the respiratory rate? Well, we have to go back to Milan, and now I'm really preaching to the Pope, because Luciano Gattinoni published this now exactly, or pretty much exactly 10 years ago, when he was between Milan and Göttingen, together with Massimo Cossoni and David Gemello. So this mechanical power. So mechanical power is a concept that integrates harm from high tidal volumes, harm from high pressures, driving pressures, and the respiratory rate into a single integer that is supposed to depict the intensity that is applied to the respiratory system, and ideally the lung, during mechanical ventilation. And this is just from a small study or publication we did in ICM a few years ago. What mechanical power in the end is basically its work doing the inspiratory respiratory cycle and multiplied with the respiratory rate. And you can already see, so you have, what you basically have is, if you integrate the airway pressure over the tidal volume during the inspiratory phase, you get these like two two types. So one is dynamic work that is exerted during the inspiration, and the other one, and this word doesn't really exist because there is no static work, but it's basically like a static component from PEEP. And when you multiply this with the respiratory rate, you get the dynamic power. And the Gattinoni and colleagues, they, as you know, they published an abbreviated formula for the use in observational studies. There are a lot of questions still with this concept, of course, because if you integrate PEEP into it, you're really like integrating potential or their differential effects from PEEP, of course, harmful effects from high PEEP, but also to some degree protective effects from PEEP that is just there to keep the lung open. But we're going to very briefly visit this in a second. We were one of the first groups to show that this concept of mechanical power matters also for patients undergoing mechanical ventilation in the OR. So again, a combined group from MGH and Boston patients, where we saw that each increase of 5 joules per minute in mechanical power was associated with a 30% increased risk of reintubation. So a very clinically relevant outcome. For perspective, the average mechanical power in this OR cohort was about 7 joules per minute. But it reached substantially, as you can see here, between about 3 to 5 until 50. So that's an increase in mechanical power of 5 joules per minute. So on average reflected an increase in tidal volume from 6 to 8 and from a respiratory rate from 10 to 15. So that's in a clinically relevant range. And then in another study that we published 2 years ago, we looked into whether this concept can even help when transitioning patients from the operating room to the intensive care unit. And this is a really peculiar and I think very under-investigated setting because, first of all, transition periods in the hospital are always associated with impacts on patient outcome. And second, this is a transition period between two very different environments. And even though many physicians work in the ICU and many physicians work in the OR, we've seen that the mechanical ventilation practices in the ICU still very much differ compared to the operating room. And especially in our patients, you can see this is the change on average in these patients that were transitioned undergoing mechanical ventilation and transitioned from the OR to ICU. You can see that the tidal volume upon arrival was immediately reduced. The driving pressures were lower, but that was at the cost of much higher respiratory rates. And on average, mechanical power didn't change much, but these are just the average values and this transition. So you see they so nicely depict the differences and the culture: tidal volume down, respiratory rate up. But these are patients that underwent surgery, so they are very different from ARDS patients. And what we saw then was when these adjustments in ventilator settings led to a higher mechanical power, this translated into higher risk of 28-day mortality. So in these patients with mostly healthy lungs, a higher respiratory rate and then successful in extension, higher mechanical power was associated with 28-day mortality, increased 28-day mortality. And again, this is what we call a dominance analysis. So it basically depicts you the relevance of the individual components of your primary exposure of mechanical power. So respiratory rate, driving pressure, tidal volume, and the effect on mortality again was really driven here by the respiratory rate component of mechanical power. I'm coming just towards the end. The mechanical power concept isn't perfect, of course. It's an approximation like any other concept in clinical medicine, and of course, there's always some flaws, and it's a nascent concept, so it's still evolving. So one thing is that the absolute tidal volume is part of this mechanical power concept, and therefore it only accounts indirectly for the patient's respiratory system compliance through a driving pressure component. And what we saw in this study that we published last year was that between male and female patients, different thresholds in mechanical power lead to very different risks of 28-day mortality. So some groups postulated a threshold of 17 joules per minute as a threshold for mortality, as a threshold for injurious mechanical power. We already see based on this graph that there is actually no real threshold. But what you can see is that the mortality risk among males at 17 joules per minute is much lower than for females. So if you ventilate both sexes the same with 17 joules per minute, you reach a much higher risk of mortality among female patients. So you have to reduce this much more in female patients. And what we then saw is when we adjust the mechanical power to the patient's respiratory system compliance, and this difference almost went away. And you can again see that when you stratify patients by different respiratory system compliance, you get very different thresholds for harm in these patients. So the same mechanical power will yield very different 28-day mortality effects among patients with a different respiratory system compliance. So that's number one. Number two, and these are very fresh data that we have not published yet, is the incorporation of the PEEP component into mechanical power. And these are data from a decremental PEEP trial in patients undergoing in the OR. And what we looked at was, we looked at the mechanical work. So we looked at basically the mechanical power for each breath. So if you take respiratory rate out, it's mechanical work. And what we saw was around the optimum PEEP, when PEEP was increased, that always, and we're looking now at the black line here, led to an increase in mechanical power. This is this mechanical work total. So that's mechanical work as calculated originally by Gattinoni and colleagues. And only when you look at the dynamic component, so you take PEEP out of the mechanical work equation, then the optimum PEEP was really linked to the lowest mechanical work as well. So that also speaks to the fact that mechanical power by itself should not be used to titrate PEEP. And ideally, you should probably titrate PEEP first and then further tailor your mechanical ventilation based on mechanical power. This is also linked to outcomes. So this is a secondary analysis of the EPVent-2 trial that's been unpublished yet, where we looked into the EPVent-2 trial titrated PEEP using esophageal manometry. And we looked at the changes in mechanical power over this PEEP titration period. And when we calculate the total mechanical power, the PEEP titration itself and any successive changes in mechanical power were not associated with patient mortality. But when we only looked at the dynamic mechanical power over the PEEP titration, we saw that that there was basically an association between lower mechanical power and lower 28-day risk of mortality. So for predicting, especially like looking into changes in mechanical and in PEEP, the PEEP component has to be taken out of mechanical power. Very last thing, we talked about keeping the lungs open, individualizing or opening up the lungs during mechanical ventilation. We talked about driving pressure and the impact of tidal volume. What is also really important is to keep your lungs open and consider other stimuli. These are, again, data that are hopefully soon to be published there in the second revision now, where we randomize patients to 70%, so to different levels of FiO2 just for anesthesia washout. So for the ICU residents at the end of anesthesia, when you use volatile anesthetics, usually the anesthesiologist cranks up the fresh gas flow, which means like it washes out the volatile anesthetic. And a lot of anesthesiologists just do this with pure oxygen, at least in the United States. I know when I was in Germany, it was also the same. Of course, pure oxygen creates atelectasis. And what we were able to show here was that when patients received lower FiO2s for anesthetic gas washout, the end expiratory lung volume measured, or the change in expiratory lung volume measured in using electrical impedance tomography was much more favorable in patients not receiving 100% FiO2. So basically there was less atelectasis formation, and especially the SpO2, the saturation after extubation, was much higher here in these like dark blue dots, which represent the 70% FiO2 group. And you could see in the 40% FiO2 group, it dropped, but then came up again. And in the 100% FiO2 group, you had kind of delayed desaturations. And some patients, like severe desaturations below 90 really just occurred in the in the 100% FiO2 group. So overall, when we look back at our concept of intraoperative lung injury and these different trauma stimuli, individualization affects a lot of these steps. We can individualize PEEP to reduce the driving pressure. We can individualize tidal volume also to reduce the driving pressure. Both will reduce stress and strain, or one will reduce strain, the other one stress. We can individualize repetition through modifying our respiratory rate. And of course, we can then also individualize cyclic collapse and hopefully impact pulmonary complications in our patients. So as a take-home message, intraoperative mechanical ventilation matters. It's really important to check your patient respiratory mechanics, both from a clinical but also just from a teaching standpoint. Measure your driving pressure. Teach your residents how to measure the driving pressure. Reduce the tidal volume if needed. And most importantly, select an appropriate PEEP. And integrative concepts around ventilation intensity, mechanical power will probably further guide us in the future, also in these transition periods when we move patients to the ICU. Thank you very much. Of course, I have to end with a positive note. There will always be a next World Cup. There will always be another opportunity for Italy to beat Germany and cause more trauma. And I still hope that you can enjoy the summer. If anybody is interested in collaborating, come either visit us, write us, visit our homepage, the Perioperative Outcomes Lab in Boston. In addition to all the research that we're doing, we're not just nerds sitting in front of our computers. We actually go out. We have a lot of fun. We also visit neighboring hospitals like the MGH. And yes, thank you so much for listening. And for me, it's been a really great pleasure talking to you guys. I just hope that you were still able to hear me and I didn't just talk to myself for an hour now.
Okay. So we have some questions from the audience. Let's start with the first one. So thank you indeed for the presentation. And so first question, in your daily practice, how do you set tidal volume and PEEP in abdominal and thoracic surgery? When do you titrate PEEP? And the third one is optimal PEEP might change according to the surgical moment, the position, pneumoperitoneum, and so on.
Yes, exactly. And that's exactly what I tried to convey with this little example of these different situations, right? So, so for thoracic surgery, we have actually a pretty standard protocol. We intubate our patients. We start 2-lung ventilation with a tidal volume of 8 cc's per kilogram ideal body weight. They're being positioned. We go on 1-lung ventilation. Once we're on 1-lung ventilation, we titrate PEEP. And in this position, and then we ventilate our patient with 5 milliliters per kilogram ideal body weight and check the driving pressure. And if the driving pressure is substantially higher than 12 to 13 centimeters of water, we reduce it. If it's substantially lower, we know that we have some time to increase the tidal volume if you want to increase minute ventilation. During the cases with 1-lung ventilation, once the patient's in the lateral position and the surgeons have access, usually not much changes anymore. So we will rarely retitrate PEEP unless there's like there's desaturations, or maybe we didn't get it right the first time and there's a suspicion for this. But this is usually a setting where you don't have to retitrate it that much. In patients undergoing robotic surgeries, I personally retitrate PEEP after every major positioning change. So that's what I try to convey. If you, especially in this patient scenario, the patient initially in the supine position required a PEEP of 10. After steep Trendelenburg and the insufflation of the abdomen PEEP was 24 all of a sudden. And this is, I think, where it's really important to have some measure of PEEP titration that you can do in a short amount of time, even if it's not maybe 100% the gold standard, but you need to reassess this. And yeah, and that's what we're trying to do. And then actually when the patient is back in the supine position, we just go back to the initial settings and then extubate the patient.
Okay, second question. In the context of individualization, are there any data evaluating the impact of time? For example, duration of intraoperative ventilation or incidence of PPC, and worse outcomes?
Yeah, so that's of course. So in imperative mechanical ventilation, there was a secondary analysis recently, and to be honest, I'm blanking out from which study, that raised a little bit the question if mechanical power by itself is really important, or if it's just the duration of the stimulus over time. I think it's a bit inherent to the concept, right? I think what mechanical power really nicely depicts is this the repetition through integration of the respiratory rate. And then, of course, you have to postulate that if you not just repeating it more often per minute, but also over a longer amount of time, you'll have more more lung injury. And this is also what all the animal studies show. The longer you ventilate patients with a noxious injury, the more lung damage you have. That's just like classic dose-dependent relationship, which to me just doesn't invalidate it, but it supports these concepts. They're inherent to these concepts. So yes, we know longer surgeries that are associated with higher risk of pulmonary complications. Basically, the duration of surgery is incorporated in almost any major risk prediction score, like the ARISCAT score or Las Vegas also. So it is also very much about the duration of mechanical ventilation for sure.
Okay.
But that's extremely hard to randomize, right? Like if you cannot just randomize patients to 6 versus 12 hours of surgery. Maybe you can randomize them to good versus bad surgeons, and you kind of get like an inherent effect. But it's very, very difficult to disentangle. Sorry.
Here there is a provocative question that is, do you think that the specific ventilation settings really matters for surgery below 2-3 hours?
Well, if you have a patient with poor compliance undergoing one lung ventilation, maybe with a DLCO of 20 and an FEV1 of, I don't know, 10%, titrating PEEP will help you get this patient through surgery, even if it's just 1 hour of one lung ventilation. So yeah, it matters for intraoperative oxygenation for sure. The data are abundant, and also for 2-lung ventilation, especially 1-lung ventilation, based on the thing. It doesn't, of course, probably always matter for every individual patient in terms of major complication. But then again, what does, right? Even and that would mean you have 100% effect size. That you don't even get in ARDS patients. And again, yes, we have a shorter duration of noxious stimuli in the OR, but we're also treating much more patients with this. So the multiplicator from the smaller effect sizes is the sheer amount of patients that we impact. And any anesthesiologist over their career will see tens of thousands of patients. So it will matter in the larger run. And this is why we need these outcome studies that we're doing, because you need the large sample sizes also to detect some of these things.
Okay, next question. Could you please elaborate on the concept of intraoperative mechanical ventilation in patients with high respiratory system compliance?
Yes. So what in the end, the driving pressure is nothing but the interaction of tidal volume and respiratory system compliance and PEEP. At the same, let's say we optimize PEEP, then it's only a matter of compliance and tidal volume. And so you achieve in patients with a poor respiratory system compliance, reducing the tidal volume will achieve much lower driving pressures in patients than in patients with a good respiratory system compliance. So when you have a larger area where your intraoperative compliance is always optimum, you can ventilate them with different tidal volumes, and the effect on driving pressure will be much less. Whereas in patients with a poor compliance, you need to reduce your tidal volume much more substantially, and then you already to get to the same driving pressure thresholds. So it's really about this interaction that results in lower driving pressures then.
Do you suggest the use of recruitment after all the surgery in order to reverse atelectasis? When to do it and when not?
Yeah, recruitment maneuvers. I think if ask a ICU physician if they suggest recruitment maneuvers, they're probably like be prone to say no comment. So ideally, you avoid atelectasis formation in the first place, right? So ideally, you titrate your PEEP, you modify PEEP titration for or you modify your PEEP after any major changes in intraoperative positioning and so on. I personally like recruitment maneuvers, also driven in one-arm ventilation, yes, but they always, if a recruitment maneuver is successful, it always shows you that the PEEP before probably wasn't insufficient. At least that's my clinical take on this. The immediate post-extubation period, atelectasis can impact oxygenation and then reintubation, and we showed this a little bit with this study in different FiO2s, where we saw that this impact on atelectasis formation or more loss in FRC led also to much more unstable SpO2 values. So that's another reason why maybe one recruitment maneuver before extubation is not a bad idea. But if you, again, depends on when you're doing the recruitment maneuver. So if you're doing it toward the end of surgery and then continue to ventilate with an insufficient PEEP, or if your transition period is a practice where you, as we say in Germany, you let the patient hanging, so you let them on a mechanical, on a manual mode for a certain amount of time in order to increase end-tidal CO2 and then stimulate breathing, they'll de-recruit again after this. So you have to also time it right and then keep the lung open afterwards. But very few data in the operating room setting. The recruitment maneuver was part of the IMPROVE study also and the intervention group. So in this study bundle, you can probably recommend it. But we also know that recruitment maneuvers can do a lot of harm based on the ICU studies.
Okay. If the running pressure changes so much with position, do you think that this is mainly due to change in chest wall compliance? If so, does it have an effect on transpulmonary pressure?
Yes, excellent question. So hard to answer. So actually, that's something we have debated also when designing a trial that we're currently conducting. So the question is, are you talking about end inspiratory or are you talking about end expiratory transpulmonary pressure? The end inspiratory transpulmonary pressure probably doesn't change much. Even if you see higher plateau pressures, you have, as you correctly said, a lower chest wall compliance or probably higher intrapleural pressures that will balance this. But what substantially changes is the end expiratory transpulmonary pressure. So they basically what happens in steep Trendelenburg position, the wide of the abdomen substantially compresses the diaphragm, and especially at the lung areas close to the diaphragm, that increases the intrapleural pressure, and that will then very much decrease the end expiratory transpulmonary pressure towards negative. So what you're doing with PEEP titration there is basically reshifting the end expiratory transpulmonary pressure, ideally towards 0 or +2, so that you keep these areas of the lung open and avoid lung collapse, and that then will affect your driving pressure. And inspiratory is a different setting, but also a definite answer I cannot give you because I would like to investigate this, but the validity of esophageal pressure management also changes with the patient position, so it's also harder to investigate. Yeah, but I think there are differential effects on end inspiratory and expiratory transpulmonary pressure.
Okay. What about the obese? Because the obese in the end will be shift the PV curve with higher BMI. Is just simply adapt the PEEP and then the same rules will follow or not?
Yeah, so ironically, obese patients don't they don't really have a poorer compliance. They have an offset. So their compliance is bad when you don't use when you under PEEP them. So when you start at a PEEP of 0. So once you individualize PEEP, obesity is not really a predictor of driving pressure. They benefit from PEEP optimization. I'm still convinced, and the obese study was a suboptimal study because it used the same PEEP for all patients. But the compliance after PEEP individualization is actually pretty similar. We only see poorer compliance because they're more often under PEEPed, and then you need some pressure to to recruit the lungs, and then the overall, like the compliance over the whole inspiratory cycle is worse.
Yeah, and I have a personal question. You show very interesting data about how ventilation changed between the OR and the ICU, for example. But what do you suggest to keep the same ventilation that was used in the OR? Maybe keep slightly higher tidal volume instead of favor an increase in respiratory rate. Which is your suggestion during this passage?
So my suggestion is not to change anything that leads to detrimental stuff in these patients. So first of all, it's the same patient. Why would they require different settings in the OR and in the ICU? I'm not saying that the patients are ventilated better in the OR, but what the study basically showed is when there's like a transition in these patients and that led to higher ventilation intensity because of the different setting, it was worse for the patient. So what we have to suggest based on this is to really check your mechanical power. If you want to like use higher respiratory rates for these patients, then see what the impact is of the changes in ventilator settings on your ventilation intensity if you're able to do that. There's a bit like the mechanical power isn't the only concept, of course, that tries to depict this. There's this like 40PRR concept from Marcelo Amato's group also. That's maybe a little bit easier to calculate at the bedside. Obviously, I personally think mechanical power is a bit more like incorporates more parameters, but that's a whole story by themselves. But again, check it. Like you don't have to necessarily just adapt all the ventilator settings that the anesthesiologist had said before. But if you want to switch the ventilator, see what are your changes in driving pressure, what are your changes in respiratory rate. What ICU physicians maybe are not always used to is that these patients can tolerate higher tidal volumes without increases in driving pressure because their compliance is better. And when we reduce the tidal volume, we don't really reduce the driving pressure that much anymore in these patients, but we have to increase the respiratory rate, and that then leads to this higher mechanical power.
Okay, thank you very much. I think no other questions are left. Okay, I think we can move on. I will give this podium to Vincenzo. Thank you very much, Max, for your excellent presentation.
Thank you for this very nice presentation. And then I don't know if you are seeing my slide.
Yes.
Yes, this is only just introducing the next meeting. We will have the pleasure to have with us Professor Mathieu Legrand from University of California, San Francisco, on the 14th of May at 4 p.m. The topic is acute kidney injury. We don't exactly know the precise title, but we will share, as usual, the title and also the link for joining. And this very nice presentation has been recorded as usual, and Professor Landoni sent the link in the chat of the YouTube channel where you can find all the previous meetings. So thanks again, Professor Schaefer, for joining us, and thanks to all of you for being here with us. See you next time.
Thank you. It was a great pleasure. Really.
Thank you.
Bye.
Thank you so much.
Thank you. Bye.
Thank you.
Thank
Bye.
you. Bye. Bye. Thank you.